So, we will start with the starting principles of insulin therapy. We have already covered some part, but due to the technical glitch, again, the session got ended abruptly. Sorry for the inconvenience. So, uh, we will start from what where we left over. So, we were covering about the basal bolus initiation, when to choose. So, basal bolus initiation is chosen under diabetes 1 condition, type 1 diabetes 1 condition, type 2 uncontrolled basal alone condition. And the after the initiation, I told you that titrate gradually. So during titration, add prandial insulin progressively, which helps the basal plus, which includes the basal, and this basal bolus combination helps the transition with minimal complexity. So that was about the basal plus approach. Now moving on to the next slide. Now we will cover advanced techniques or the advanced studies which are carried for the diabetes mellitus condition and the insulin analogs. So some modern technologies come up with the studies regarding the smart delivery and closed loop which analyzes the diabetes levels quickly on a go. Modern modern trends and advanced techniques. Followed by modern systems which include uses of CGM, that is continuous glucose monitoring, plus automated insulin delivery to improve outcomes. Hybrid closed loop pumps adjust the basal in real time. Some can provide automated corrections. Example includes some platforms are there which adapt the insulin delivery algorithms using AI models. Second is the reinforcement learning algorithms. That is the continuous optimization tools. So what does it include? It includes the personalized insulin dose suggestions, improved time in range metrics, in silo studies. It highlights the future of AI-driven titration. Other innovations are new insulin analogs which came into market, which includes the ultra-long basal, that is once weekly insulin, icodec. Oral or glucose responsive formulations are under development in the market, which aim for greater convenience, better risk profiles. Now, moving on to the next part, that is blood glucose monitoring and safety red flags required referral. Now, there are some techniques or advancements are further going on in the diabetes and the monitoring of the diabetes. So it includes firstly the traditional SMBG, that is single stick glucose testing, which is a traditional method which is used since long back for the detection of the insulin or detection of the diabetes mellitus in the blood. Then continuous glucose monitoring is real-time data. It gives the real-time data, trends, alarms for the patient. Then it includes the flash glucose monitoring and emerging technologies. Latest advancements are also uh, going on, and some of the latest advancements I have put in the slide, which includes the CGM devices, AI and predictive algorithms for the glucose trends and hypoglycemic risks. And further, the research is also going on into the non-invasive monitoring. That is, optical sensors are used. Some machines include the optical sensors for detection of the glucose in the blood, which we called as the smart watches or the smart wearable devices are incorporated in the market to detect the diabetes, blood pressure. Such devices includes the optical sensors to detect the glucose in the blood. Then next part includes the safety red flags. Now, what
The next lecture is Modern Perspective for the Treatment of Diabetes. The lecture is given by Mr. Pranav Kulkarni, B.Pharm, M.Pharm Pharmaceutical Chemistry. So let's start the lecture, Modern Perspective of Diabetes Treatment. So dice is yours.
Thank you. So we will cover modern perspective of diabetes mellitus. First, we will cover anti-diabetic drugs, followed by insulin types. Thirdly, we will cover blood glucose monitoring, and fourth is complications which are covered under diabetes mellitus, their screening and treatment protocols. So these are the contents of the presentation: anti-diabetic drugs, insulin types, blood glucose monitoring, and complication screening. Firstly, moving on to the introduction part. So, what is mean by diabetes mellitus? So basically, diabetes mellitus is a chronic metabolic disorder which involves the uh, difference in the blood glucose level, persistent hyperglycemia, high blood glucose levels or low blood glucose levels, or the normal level in the of the sugar in the blood is not maintained by our body. Thereby, we need to give medications to maintain that normal blood glucose level. It is caused due to the defective insulin secretion, insulin action, or both. This was all about the definition of diabetes mellitus. Then key features of diabetes mellitus. It causes disturbance in the carbohydrate, fat, and protein metabolism. It leads to long-term organ damage. It affects pancreatic insulin regulation. And what is the main cause of the diabetes mellitus? Insulin deficiency or insulin resistance is the main cause of diabetes mellitus, which results in the impaired glucose uptake by cells. Global impact. Global impact of diabetes mellitus. One of the most prevalent non-communicable diseases uh, is considered under diabetes mellitus. It is rapidly increasing. Diabetes mellitus is rapidly increasing due to sedentary lifestyle, obesity, unhealthy diet, and genetic predisposition. And what are the clinical significance of diabetes mellitus? If it is uncontrolled, or if the value of diabetes mellitus is above the control limit, so it can cause heart disorders, kidney failure, blindness, and nerve damage. So this was all about the introduction part of diabetes mellitus. Now moving on to the classification of oral antidiabetic drugs. Antidiabetic drugs are classified under two classes. First, the drugs which enhances the insulin secretion, and second, the drugs which overcome insulin resistance. So the drugs which enhances the insulin secretion are sulfonylureas, meglitide analogs, glucagon-like peptide receptor agonists, and fourth is dipeptidyl peptidase 4 inhibitors. First is sulfonylureas blockers, that is potassium ATP channel blockers. They're under sulfonylurea, first generation, first generation, and second generation. First generation sulfonylureas carries tolbutamide. Second generation sulfonylureas carries glibenclamide, glipizide, glicazide, glipepiride. Then the drugs which enhance insulin secretion, second class is meglitinide analogs. The examples include repaglinide, netaglinide. And the third class which enhances the insulin secretion are called as the glucagon-like peptide, that is GLP-1 receptor agonists, which are generally given in injectable form. Examples include exenatide, liraglutide. Then the next class which enhances the insulin secretion is dipeptidyl peptidase 4 DPP4 inhibitors. So examples of DPP4 inhibitors includes sitagliptin, vildagliptin, sexagliptin, alogliptin, linagliptin. Then the antidiabetic drugs second part, which overcomes the insulin resistance. The drugs which overcome the insulin resistance, first class is bigonides, that is AMPK activators. So the drug which activate the AMPK channel is metformin. And the second class which overcome the insulin resistance is thiazolidinediones, which is also known as PPAR gamma activator. The drug which activates this channel PPAR gamma is pioglitazone. Then there are some other miscellaneous agents which overcome the insulin resistance, which include alpha glucosidase inhibitors. The alpha glucosidase inhibitors uh, include acarbose, miglitol, vogliblos. Then amylin analog. The miscellaneous class also includes amylin analogs. So the best example for amylin analog is pramlintide. Then the third class, which is also known as the dopamine D2 receptor agonist, which is categorized under miscellaneous class only for the insulin resistance, which overcome the insulin resistance. So the best example for this is bromocriptine. Then the fourth one is the sodium glucose cotransport 2, that is SGLT2 inhibitor. So the drugs which inhibit this channel, that is sodium glucose cotransporter channel, is dapagliflozin. So this was all about the classification of oral antidiabetic drugs. We saw about two types. First the class of drugs which enhances the insulin secretion. Then the second one was the drugs which overcome the insulin resistance. Then we will study in depth about this classes of drugs, mechanism action, adverse effects, pharmacokinetic study, and other uses of these drugs. Now moving on to the next slide. So these are the sorry. So this is the site of action for site of action site of action for the oral therapies for type 2 diabetes. So the classes of drugs which we studied in the previous slide, here their site of action is described. Meglitinide analog, that is sulfonylurea, acts on the pancreas. Alpha glucosidase inhibitors acts on the glucose or gut area. Then there is thiazolidinediones, which acts on the adipose or muscles area. Then metformin bigonides, it acts on the liver, which The sites for the oral therapies or the site where the diabetes is affected is also described in this image. Say, for example, pancreas is affected, then gut or muscle area is affected, then liver organ is also affected in the diabetes mellitus. So that was all about the site for the oral therapies for type 2 diabetes. Then moving on. This is a pictorial representation of the mechanism action of various diabetes mellitus drugs, where we can see that there are various channels on this cell. Say, for example, there is calcium channel, there is insulin C-peptide APP channel, then GLUT channel, where glucose is influx. Then here we can say that in this picture we can see ATP sensitive potassium channel. So here the mechanism action of various anti-diabetic drugs is described. Incretin receptor is also shown in this image. So basically, from this picture, we can say that the drugs which act on this such type of channels blocks the entry or it reduces the influx of the glucose or the calcium, thereby decreasing or increasing the thereby increasing or decreasing the insulin secretion or glucose intake or uptake. So that was the broad explanation for the diabetes mellitus, how diabetes mellitus drugs works on the cell. Then next, sulfonylurea, which is also known as the potassium ATP channel blockers. Sulfonylurea potassium ATP channel blockers are also known as insulin secretagogue. It requires at least 30% functional beta cells to work for this sulfonylurea class. The examples I already described here are glibenclamide, gliclazide, glipizide, or glimepirides. These all drugs comes under sulfonylurea, potassium ATP channel blockers. So what is the mechanism action of this sulfonylureas? It basically increases the insulin secretion by acting on sulfonylurea receptor at ATP sensitive potassium channels. It acts by blocking the potassium ATP channel that reduces the influx of rectifying potassium ion current. So basically, this sulfonylurea, when gets attached on the sulfonylurea receptor at the ATP sensitive potassium channel, the insulin secretion is increased. Thereby, the disturbance in the insulin in the cell is normalized, and the insulin level is reached to a normal level. Depolarization of the pancreatic beta cells is also will also happen, and it increases the influx of the calcium ions as well as the release of the calcium from the intracellular stores, and it promotes the exocytotic release of the insulin. So there are two types of channels: potassium ATP channel blockers, where the potassium channel is blocked, but simultaneously depolarization of pancreatic beta cells is also happening. Thereby it results into the influx of the calcium ions and release of calcium from the intracellular stores. So two types. So this mechanism can be explained in two ways. Firstly, potassium ATP channels are blocked, thereby potassium release is blocked. Secondly, depolarization of pancreatic beta cells is occurring, thereby calcium channels are opened and calcium influx is increased, and which in turn results into the exocytic release of the insulin. But there is a warning. What is the warning? So sulfonylurea after chronic use sensitizes the target tissue to the action of insulin. So chronic use is not recommended. Also, slow hepatic degradation of insulin can also happen, and next it reduces the glucagon secretion. Now, what is we will study in this slide the pharmacokinetics of sulfonylureas. So, first point is well absorbed orally. For sulfonylureas are the type of drugs which are well absorbed orally when taken orally. It includes the high plasma protein bound percentage, that is 90%. The drugs are plasma protein bound. Very much high percentage is pronounced, that is 90% is there. Single daily dose is sufficient. So in some patients we can say that there are multiple doses for diabetes mellitus, 2 times, 3 times, or after meals, before meals. But when we prescribe sulfonylurea, when a doctor prescribes sulfonylurea, single dose is sufficient to act for the insulin normalization. Now, this was all about the pharmacokinetic study, but what about the adverse effects of sulfonylurea? So, sulfonylurea is given for the treatment of diabetes mellitus, but in the other sense, it on the if taken beyond the therapeutic range or therapeutic value, it can give hypoglycemia to a patient. That is decrease in sugar level. Non-specific side effects include weight gain, nausea, vomiting, flatulence, diarrhea, and other symptoms can also be profoundly found. Then in some patients, we can see hypersensitivity reactions can also occur, which includes photosensitivity reactions, rashes, purpura, transient leukopenia, rarely agranulocytocytes. So this was all about the hypersensitivity adverse effects. Hypoglycemia is the first type of adverse effect. Second is the weight gain, nausea, vomiting, and other symptoms can also be seen. And hypersensitivity reactions can also be seen if taken beyond the therapeutic range. Flushing disulfiram-like reactions can also be seen if taken beyond the therapeutic range. And there is a warning sign for this sulfonylurea prescription. It should not be used in pregnancy and lactating mothers. So if a mother or a lactating mother or a pregnant woman is taking the diabetes mellitus drug, specifically sulfonylurea, it should be avoided. It is not recommended to take sulfonylureas in the pregnancy and lactating mothers. So this was all about the adverse effects and pharmacokinetic study of the sulfonylureas. So this is the pictorial representation or diagrammatic description of how sulfonylureas act and how insulin secretion is normalized. So here in this picture, we can see that there is a potassium channel in the upfront. Secondly, below there is a calcium influx or calcium channel depolarization is taking place. As described in the paragraph under the mechanism action, this is the pictorial representation of how the sulfonylureas gets attached onto the potassium channel, and potassium channel release is blocked. That is, it closes the potassium channel. Hence, it is called as potassium channel blocker or K plus ATP blocker. Once this potassium channel is blocked, thereby calcium channel opens, that is depolarization of calcium channel occurs. So calcium from outside gets inside into the cell, that is influx of calcium occurs, thereby resulting into the exocytosis of the cell. Exocytosis means the insulin inside the cell gets released into the outside medium of the cell, thereby the insulin percentage in the inside of the cell and the insulin percentage in the outside of the cell is maintained, and thereby the insulin release inside the blood is maintained. So the insulin level normalizes. So this is how the sulfonylurea drugs works. Now moving on to the next class of the diabetes mellitus drug, that is meglitinide, phenylalanine analogs. So what is the mechanism action? How meglitinide or phenylalanine analogs works? So potassium ATP channel blockers, they are the potassium ATP channel blockers. It gives quick and short lasting action. It normalizes the mealtime glucose levels. Best examples for meglitinide analogs is repaglinide and netaglinide. So repaglinide and netaglinide quickly gets absorbed and rapidly gets metabolized. This is the first advantage of the repaglinide and netaglinide. It quickly gets absorbed and rapidly gets metabolized. It is administered before each major meal, and if it is omitted if meal is missed. Means repaglinide and netaglinide dose is omitted if meal is missed. So the administration of the repaglinide and netaglinide is based on the meals. How much meal or time of the meal, lunch or dinner. So it is based on that administration. So it is administered before each major meal and it is omitted if meal is missed. Lower incidence of hypoglycemia. We can see that sulfonylurea can cause hypoglycemia, but rapaglinide and nataglinide, if administered, it gives lower incidence of hypoglycemia. Now, what is the indication for this metaglinide or diabetes mellitus? Which type of diabetes mellitus? Which type of diabetes mellitus uh, is used or treated for this rapaglinide and nataglinide? So, type 2 diabetes mellitus with pronounced postprandial hyperglycemia is the use for rapaglinide and nataglinide, along with metformin, long-acting insulin. What this point means that rapaglinide plus metformin or nataglinide plus metformin, the combination of both gives longer acting insulin. That is, insulin concentration is maintained on a longer action or longer time in the blood when prescribed with metformin. Metformin is another class of drug for the diabetes mellitus. Its mechanism of action is also different. But when we combine, when the doctors prescribe in a combined format or the multi-dose format, rapaglinide plus metformin or nataglinide plus metformin, it gives long-acting insulin release. What are the side effects of maglatinide or maglatinide class of drugs or rapaglinide and nataglinide? So when you are taking rapaglinide or nataglinide, we can see mild headaches, dyspepsia, arthralgia, and weight gain. So if a patient, there is a warning sign for this. So if a patient, as in a sulfonylurea class, my pregnant woman or lactating mothers are not allowed, or it is not recommended to prescribe to lactating mothers or the pregnant woman. But same goes with the maglatinide class of drugs. That is, rapaglinide and maglatinide is not recommended if a patient is having liver disorder or liver diseases or liver cirrhosis. So this is a warning sign. So this is the pictorial representation of how sulfonylurea and maglatinide class of drugs works. So here in the picture, we can see that glucose is entered from a outside to inside via GLUT receptor or the GLUT channel, GLUT2 channel. After which glucose is converted to glucose 6-phosphate by the enzyme glucokinase, where glucose 6-phosphate is also further converted to ATP or ADP via mitochondrial metabolism. And this ATP or ADP gets depolarized to through potassium channel blockers or potassium channel channels, and where the potassium channel, the site for the sulfonylurea is this potassium channel. So sulfonylurea gets attached to this potassium channel, and potassium depolarization or the potassium influx or the potassium channels are blocked, means the outside potassium cannot enter into the inside cell of the potassium, and which results into the depolarization of the cell. What does that depolarization of cell means? That means that the outside cell of the calcium, that is the calcium which is outside of the cell, gets entry into the inside the cell. That is, influx of calcium takes place. That is called as L-type calcium channel, through L-type calcium channels, which in turn results into the exocytosis. What does that mean, exocytosis? That is the insulin which is in abnormal range. That is why the diabetes mellitus is causing, or the patient is having diabetes mellitus. So the insulin which is in the abnormal range, or it is not normalized in the cell or in the blood, gets released as soon as this calcium enters into the cell. So this is how maglatinide analogs or the sulfonylurea class of drugs works. So this was all about the pictorial representation or the mechanism action of how sulfonylurea or maglatinide anti-diabetic drugs works. Now moving on to the glucagon-like peptide, that is another class of the anti-diabetic drugs. That is glucagon-like peptide 1 GLP-1 receptor agonist. There are two types, that is agonist and antagonist. So agonists are in favor of the receptor. Antagonists are against provide the opposite action to the receptor action. So this is the another class which is called as glucagon like peptide, that is similar action receptor agonist. So what is the mechanism action of how this GLP-1 receptor agonist works? So GLP-1 is an important incretin release from the gut in response to the ingested glucose. It induces insulin release from the pancreatic beta cells, inhibits glucagon release from alpha cells, slows gastric emptying, and suppresses appetite. So this was the mechanism action. So this GLP-1 is an important incretin release. So it is an incretin which is released from the gut. So the site of action is gut in response to the ingested glucose. So if a patient, if he or she is continuously eating or having sugar, so the ingested glucose comes into play, or the sugar is converted into glucose and glucose level in the blood increases. So it induces insulin release. As soon as the glucose increases, so insulin release occurs in the cell. It induces insulin release from the pancreatic beta cells, which inhibits glucagon release from the alpha cells, and which slows the gastric emptying and suppresses the appetite. So the appetite or the ap- the appetite increasing quality of the patient is decreased. So the glucose from outside is stopped. And as soon as the glucose from outside is stopped, so the insulin which is released from the pancreatic beta cell is also stopped. So that is how the glucagon release from alpha cell is inhibited, and gastric emptying is also slowed down. So this was all about the mechanism of action of glucagon like peptide 1 receptor. Exenatide. So this is the classic example for glucagon 1 glucagon like peptide receptor. So what is mean by the exenatide? How it works, or how what is the synthetic diagram or the structure for this exenatide? So synthetic dipeptyl peptidase 4 enzyme resistant analog. Exenatide is synthetic dipeptidyl peptidase 4 enzyme resistant analog. It activates the GLP receptor. Cannot be given orally. So this exenatide is the one which is DPP4 enzyme resistant analog, firstly. Secondly, it activates the GLP receptor, that is glucagon 1 receptor. So the site of action for this exenatide is GLP-1 receptor. Then the third point is it cannot be given orally. We cannot give this glucagon receptor agonist drugs or exenatide or another other type of drugs under this category orally. It must be given by other routes only. Then fourth point is used as an add-on drug to metformin, sulfonylurea, or pioglitazone. So what does that line mean? So it is add-on drug to metformin, sulfonylurea, pioglitazone. Yes, can I continue? Okay. So use as an add-on drug to metformin, sulfonylurea, pioglitazone. It lowers prostaglandin as well as fasting blood glucose, HbA1c, and body weight. So what does that exenatide does or do? It lowers the postprandial as well as fasting blood glucose. Postprandial means the glucose level is checked after meals, as well as fasting blood glucose, that is before meals. Two types of the blood glucose or the blood glucose test is done. Postprandial means after the meal, and fasting blood glucose is before the meal. And HbA1c is a diagnostic tool or the test we perform to check the blood glucose levels. So it lowers both postprandial as well as fasting blood glucose. HbA1c, and body weight. And what does the exenatide do if taken beyond the therapeutic range? That is, what are the side effects of exenatide? So it causes nausea, vomiting, tolerance develop later. Tolerance develop later means if you are giving exenatide or GLP-1 receptor agonist continuously beyond the therapeutic range, or so side effect can be that it develop tolerance. So the mechanism action or the action of exenatide is decrease as you increases the chronic use of exenatide. So that is the reason they are saying that tolerance develops later. Then next class is for the glucagon like peptide receptor agonist is liraglutide. Another example is liraglutide. Highly bound to plasma proteins, longer duration action. So it is highly bound to plasma protein. There are plasma proteins. So the drug is highly bound to the plasma proteins, and due to which, as a result, it causes longer duration of action. So GLP-1 receptor agonist mechanism of action. This is the pictorial representation of how GLP-1 receptor agonist works. So as soon as food enters or the sugar level inside the food is entered into the body, it goes into the small intestine for the digestion. Then followed by it as soon as it reaches the body or the small intestine portion, it secretes GLP-1 in the response to food. So GLP-1 is glucagon-like receptor or glucagon-like protein. Glucagon-like protein 1 is secreted in response to the food which we ingested or which the patient has ingested. So this GLP-1 decreases the appetite, slows down the gastric emptying, which reaches the brain as well as stomach and pancreas. So which after stimulates the insulin secretion, means as soon as the GLP-1 is released, it reaches the three parts, that is brain, pancreas, and stomach. As soon as GLP-1 reaches the pancreas, it stimulates the insulin secretion and insulin is released. But this glucagon like 1 receptor agonist or the GLP-1 receptor agonist, that is exenatide or liraglutide, what does that this type of drugs do? It suppresses the glucagon secretion, which does not release the glucagon. As the glucagon is not released, so insulin is not released. So gastric emptying is slower down. So as soon as the gastric emptying is slower down, it decreases the appetite. So as soon as the appetite is decreased, so the intake, so the glucose or insulin from the food which is ingested is not released. So this is how the mechanism action of glucagon 1 like receptor agonist works. So this was the pictorial representation of GLP-1 receptor agonist. Then the next class is dipeptidyl peptidase 4, that is DPP4 inhibitors. This is what we are all covering about the anti-diabetic drugs only. The next class of anti-diabetic drug is DPP4, that is dipeptidyl peptidase 4 inhibitors. What does that mean? Dipeptidyl peptidase 4 does. So DPP4 enzyme causes the rapid degradation of the endogenous GLP-1. The GLP-1 which is released inside the cell after the food intake, it causes the rapid degradation of that GLP-1. As soon as the degradation of GLP-1 occurs, orally active inhibitors of this enzyme has been developed as indirectly acting insulin secretagogue. So, what does that line mean? DPP4 enzyme causes the rapid degradation of endogenous GLP-1. But thus, as a result, what does that mean? That causes the orally active inhibitors of this enzyme, means the DPP4 enzyme or the secretagogue has been introduced in the market, which causes the rapid degradation of this GLP-1. And that is the reason as soon as the GLP-1 endogenous GLP-1 is degraded, so this enzyme, DPP4 enzyme, is the main cause for this rapid degradation of endogenous GLP-1. And that is the reason in the market recent advance or techniques are developed where the insulin secretagogues are indirectly administered or indirectly acting on this type of class of drugs. So the best example to explain this type of DPP4 inhibitors is sitagliptin. So what is the mechanism of action of sitagliptin? It acts as a competitive and selective DPP4 inhibitor and potentiates the action of GLP-1 and GIP. So what does that line mean? So I will explain. Acts as a competitive and selective DPP4 inhibitor. Means sitagliptin is a selective DPP4 inhibitor as well as it competes with the other class of DPP4 inhibitors. And it potentiates the action of GLP-1, that is glucagon-like peptide 1 receptor. It potentiates the action. And it also potentiates the action of GLP-1 and GIP. That is also a glucagon-like peptide only. Next point, it boosts the postprandial release, decreases the glucagon secretion, and lowers the meal time as well as the fasting blood glucose in the type 2 diabetes. So what does that line mean? It boosts the postprandial release. Means as soon as meal is entered and the blood glucose level is increased. So the it boosts sitagliptin boost postprandial release.